Good afternoon and good morning to you if you are on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing. Thank you so much for attending this live event exploring cultural competence and humility in the care of HIV patients. The National Center for Health and Public Housing is founded by HRSA to provide training and technical assistance to health centers close to or immediately accessible to public housing. There are around 107 public housing primary care grantees and over 380 health centers providing services to public housing residents in the United States. As I said, this is a live webinar, so all lines are muted. And if you have any questions, please save your questions to the end. And you can either use the chat box and type your question, or you can also use your raise hand icon and your line will be unmuted. The learning objectives for this session are to establish the relevance of cultural humility as a key strategy in response to HIV stigma among women of color, identify the impact of stigma in healthcare among women, describe the impact of cultural humility on patient access, use, and trust in HIV healthcare services, and discuss why and how culturally humble client-centered services support access to and the continuous engagement in HIV prevention and care services. There are around 2.2 million residents living in public housing. 38% of them are children, and around 59% of them are female. 55% of them have less than high school diploma, and around 83% of them are below the federal poverty line. So as you can see, this is a population that has a lot of social determinants of health and is affected by a lot of social determinants of health, and they are in great need of healthcare services. You see the population, we have children, we have female patients, and remember that the people applying for public housing are basically patients with HIV/AIDS, patients or people over the age of 65, and those coming out of prison. All of these are vulnerable populations. As I said, there are around, this is 2017 data, but the 2018 data from HRSA says that there are over 385 health centers serving public housing residents, and around 107 are public housing primary care grantees. I am going to skip this. This is about the number of units and how the public housing program is diminishing because HUD is changing from the traditional public housing to basically Section 8 or voucher. In regards to the health picture of those living in public housing, we see here that diabetes, COPD, asthma, obesity are some of the chronic conditions affecting those living in public housing. And as you can see, those are these conditions are more prevalent in those either living in public housing or receiving assistance from HUD. And this is information. This is 2018 data from UDS. This is the number of patients being served or that were served in 2018. Patients with either symptomatic HIV or patients asymptomatic, as well as the number of tests that they received during the last visits. This is the population served by those living in public, or at least being served by the public housing primary care grantees, and the LGBTQIA population being served in all the federally qualified health centers across the nation. So it's such a great pleasure to introduce today's speaker. We're going to hear from Lisha McKinley-Beach. She serves as a HIV prevention consultant with several health departments and organizations. In this role, Lisha provides capacity building assistance and training for health departments, prep training for providers serving Black populations, Black women initiatives, and the facilitation for local health planning coalitions. She has also launched several projects thought for the day, a podcast providing inspirational messages, a future podcast on HIV launching in June 2020, ending HIV for humanity everywhere. You can visit her website, www.licia.org, for more information on her initiatives. And Licia is a graduate from the University of West Florida and the University of Florida. Thank you, Licia, and you can take it from here.
Thank you so much, Jose. Can you hear me?
We can hear you very well.
Okay, awesome. Again, thank you for having me, and also thank you to the Southern AIDS Coalition and Mr. Harris for inviting me to participate on today's webinar. And so we're going to spend the next couple of minutes talking about cultural humility and stigma and its outcomes for Black women and HIV. Our learning objectives for today will focus on, again, cultural humility, but also looking at how stigma plays a role in the health outcomes for Black women, and how that is framed in terms of healthcare, access to healthcare, trust within healthcare organizations that Black women are accessing services from. And you heard Jose mention a little bit about me. I do serve as an HIV prevention strategist. I have been doing this work for the past 29 years. I actually started my work in HIV when I was 17. Now you know how old I am. And I have always been an advocate for HIV services for Black communities, and particularly among Black women. I am a Southerner, and sometimes when I get extremely excited, you do hear that dialect. So I apologize for the Southern drawl that may come through, but it does speak to where my passion comes from as it relates to HIV in the South and our work that is necessary within Black communities. I wanted to start today by just painting a picture of why cultural humility is so important as we talk about the clients that you are serving. I was attending a meeting in a Southern Health Department, and we heard this ruckus on the outside, two women who were yelling back and forth. And so we went outside to see what was happening, and there was a case manager who was informing a client that she was contacting security to have her removed from the facility. And so I looked over at this young lady, Black female, under the age of 25, pregnant, had a baby on her hip, was holding the hand of another child. And I saw these huge crocodile tears that was rolling down her face. Now, as a mother, that really concerned me, that we were removing her from the premises and did not understand her story, why she was in such a tyrant rage. And so I asked her, I said, tell me what's going on. And she said, I'm here to be recertified for her PAPWA. And they keep asking me the same questions over and over. I'm just really frustrated today, and I don't know where my children are going to sleep tonight. And so I explained to her, you are not leaving the facility until we come up with a plan to make sure that you have housing. And by the end of that session, everything that the case manager needed her to answer, she had answered, but she also shared with us where her frustration came from. So on her way to her appointment, her car overheated. And so she's about half a mile away from the health department, and she's having to walk in the heat of the summer in a southern state with two small children and being pregnant. So she came in just frustrated and defeated. And when the case manager met with her, didn't greet her, didn't ask her about her day, immediately started on what their process was for recertification. And so for me, just being a witness to that process is a constant reminder that before we begin to look at how many patient goals that we have each day, how many folks that we are trying to see, remember that these are individuals who are more than a number. They come with stories, they come with challenges, they come with issues, and they come with culture. And it is up to us as healthcare providers to be sensitive to those needs. And so a textbook definition for culture, we all know it, that it is something that's personal and it's deeply rooted. And it is also ever changing. And I think that's the most important part to acknowledge is that, as times change, culture also changes. And so we also look at the values and beliefs as well of the people that we are serving. And that we're going to perceive things in different ways. And it doesn't mean that it's right or wrong. It is important to acknowledge that we all come with lived experiences and past experiences, and they all define who we are. And so when I think about culture, all of these roles play a part of culture. And I will say that for me, I'm not a superstitious person, may not adhere to many of the rituals that were a part of my upbringing, but there is one day out the year that my daughter would say, oh yeah, she does everything by the book of tradition. And that day is New Year's Day. And I would challenge you to identify, colleagues and co-workers, friends, and even just community folks that could talk about the significance of New Year's Day within African American communities. One example is a service that many Black churches participate in on that day, and it's called Watch Night Service, which happens on New Year's Eve. And when I was growing up, I thought all churches participated in Watch Night Service, but as I became older, I realized that this was not only specific to African American communities, it's even more specific to the southern region within the United States. And so Watch Night Service was an event that was started back during slavery as slaves gathered together waiting for the signing of the Emancipation Proclamation. And during that time, people came together and they sang, spirituals and prayed and, believed that this was going to happen. And so most people know the outcome of this story in Texas being the last state to be informed that slavery had ended, and we recognize Juneteenth. But most individuals don't know that process started 6 months prior and that different states found out at different times. And so in my home state of Florida, we also celebrate what we call May Day, because it was in the month of May when Florida found out of the signing of the Emancipation Proclamation. And so Watch Night is one of those services that I still hold true to. And then all of the activities that come along with New Year's Day, that you're supposed to cook a green vegetable and black-eyed peas with a specific pork called hog jaws, and all of those things that have been passed down from generation to generation. So those are rituals that are a part of the culture that I believe in. And then there are different layers of culture, and we're going to talk about some of these, from our personality all the way to the organizational dimensions of culture that impact our environment and our surroundings, right down to our educational background and things of that nature. The one thing about cultural humility that is so significant and important for us to acknowledge is we don't get to attend a 1-hour seminar, a semester class, and become competent or efficient or experts around cultural humility. This truly is a lifelong learning process for us, as not only we learn about different cultures, but we also acknowledge that even around us, culture is changing. And so that there has to be this commitment to wanting to learn more and understanding that the people that we serve are reflections of the ever-changing cultures around us. And just some key principles around cultural humility. Again, that this is a life learning process, and you're going to hear me say that several times. It's also an opportunity, though, to recognize and change power imbalances. And that's just a nice way of saying we often have to check our privileges as we are dealing with clients from different cultural backgrounds, and that this is a partnership. Even as we're serving our clients, this should never feel like a dictatorship. This is a partnership in how we focus on successful outcomes. And I thought Audre Lorde said it the best: it is not our differences that divide us, it's our inability to recognize, accept, and celebrate those differences. None of us are a part of a cookie-cutter process. We're all very different, from the region of the country to sexual orientation to race, and it's acknowledging those differences and being respectful of them that's important. And so when we look at cultural humility, there are different levels to cultural humility. Our interpersonal level, that speaks to us it's as an individual. It's also important to acknowledge that, we all have biases. We need to be aware of those biases and understand that when we are serving the public. And then there's the interpersonal level. And this is a part of that partnership that as we are serving our clients, to understand that I don't have all the answers. Even having whatever our organizational process is, that does not make me an expert in every client that comes through that door. And so creating this environment where this becomes more of a collaboration and not a superiority framework that will make clients be disengaged and feel like that they are part of the decision-making process. And then there's the organizational level, which is also extremely important because does the institute that I work for, create an environment that are welcoming to individuals of different diversity? Does it say so from our hiring practices to the environment of where healthcare services are being provided? A few years ago, I found myself in a very awkward situation where there had been a long-term employee that was challenged with providing services to women of trans experience. And this person would go out of their way to acknowledge women of trans experience by male pronouns. And so the organizational philosophy was that we serve the public, and our goal was to provide quality health services for anybody who walked through the door. And that type of behavior with her interpersonal behavior became more present than the organizational framework. And so as I had to terminate this individual, this person said, my religious belief will not allow me to acknowledge a man as a woman. And what that did for me was to ensure that there were more of these conversations around cultural humility and what that meant working for a public institution, that I'm not asking you, to change religion. I'm not asking you to deny your personal beliefs. What I am asking you is that as you put on that badge and you represent this public health institution, you're saying that I am committing to serve people without putting my beliefs on them or making people feel devalued for who they are when they come into this organization. And so the organizational level of how folks perceive the institution where they are receiving services is extremely important. When we look at prevention, specifically around HIV prevention with Black women, I've often said that our programs specifically focus on the end product, and that is a woman's HIV status, and that they do not address the social issues that are affecting Black women, and those are the reasons for the outcome of a woman's HIV status. And so things like gender and race cannot be separated from program design that address HIV testing or HIV care services for Black women. They have to be acknowledged and integrated into the product of how we deliver services. And acknowledging that these are intersectionalities of HIV as it relates to women, and that it's important not to shy away from those conversations, but to acknowledge that they will influence the health outcomes of Black women. even as we talk about stigma, and over the past 10 years in the HIV workforce, this has been a barrier that has been highlighted and prioritized the most. But even when we talk about stigma, you know, we have to acknowledge that yes, race and ethnicity, they do come with stigma associated to them, but that there are also other co-occurring devalued identities that feed into stigma, you know, such as women who have been incarcerated, women who have experienced homelessness, or, you know, women who are dealing with substance abuse. And all of those factors that contribute to stigma also contribute to whether a Black woman decides to hide her HIV status or not, or if she's at increased risk of HIV because of perception. And so one perception that I've heard from a group of young women who talked about being empowered and carrying condoms may be perceived as a woman who was expecting to have sex, and she may be perceived as loose. And so I don't want to carry that label. So then I don't carry the protection that I know that is necessary to prevent possible transmission. And stigma is not just a word that, you know, we look at as a barrier. Stigma is very real within many communities, and we talk about the shame and the judgment that comes not only for individuals from the interpersonal perspective, but shame and judgment that comes to family, to children, and having Black women make decisions that I can't even enter into healthcare at the organization that is closest to my home, because that organization has the word AIDS in its name, and then people are going to know what I have, or I can't access prevention services there, because if people see me going into that organization, then the perception will be that I am a Black woman living with HIV, and then how my children may be bullied. And so these are all factors that are influencing health outcomes for women who are seeking HIV prevention services, and women who should be seeking HIV care services. Even when we look at the continuum of HIV care and we see data around viral suppression, we see where percentages of viral suppression among women, among Black women, are lower than that among white women. And these factors associated with stigma do play major roles in those outcomes. In October of last year, the FDA approved the use of a medication called Descovy for HIV prevention services. With this approval came one population that was not approved for the use of Descovy. And the terminology used by the FDA was for individuals who have receptive vaginal sex. We know that is female-born women. And what a huge setback in the HIV movement to have individuals celebrate the advancement of another HIV biomedical prevention option for some groups, but not for all groups. And when I view the work that we do as an HIV workforce, it should always be for the advancement of services, prevention options, all of these strategies that's going to help support all populations in HIV, not just some populations. And so this has been a bit of frustration for me personally, but we have begun to do work, to work with the companies who created this drug, as well as with local communities, on how we continue to raise awareness about the options that women do have as it relates to pre-exposure prophylaxis, and two, to ensure that we are creating access and addressing cultural issues. Why some women may not feel comfortable even accessing the services from certain organizations. Get to that in just a second. Okay. So I had a personal experience of attending an emergency department here in Atlanta 2 years ago. I had developed pneumonia, and that was the worst feeling I have ever had in my life. And when I entered into the emergency department, I could hardly breathe. And they asked me a couple of questions, did not take a sexual history, and determined based on my responses to those questions to test me for the flu and for mono. I was quite surprised that in an urban city that has high rates of HIV, that there wasn't some question about my sexual history. And so I shared with the attending physician that I would like to have an HIV test done. And the attending physician said to me, asked me if I was a medical provider, since I'm asking for a test that he didn't order. And he should be thankful that I could hardly breathe, or this conversation would have went very differently. But what I did share with him was it was important to me to not only have an HIV test done, but also a TB, because I'm in a city that's had a TB outbreak. And I have never had any, issues around respiratory issues. And so this just doesn't make sense to me that I'm in the emergency department and I can't breathe. So he came back later and he apologized, and he said to me, if you were a man, I would have asked about your sexual history and have ordered an HIV test. But as an older woman, this was a young Black physician, and again, now he's bringing in his cultural upbringing of respecting older Black women, and he said, I just didn't know how to ask you that. And so we talked about why it was necessary that regardless of the way that you had been brought up, that your medical training needed to trump that, because there were women who have been in that emergency department who didn't know that they should be asking for an HIV test. And I said, if you are concerned about offending older Black women or women in general, just say that I want to rule some things out. HIV is one of those things. because I want to focus on what brought you into the emergency department. And so let's rule these other things out. And then he was very appreciative of that. But what it does say is that for individuals who may use the emergency department as their primary care provider, they may have come in and, again, not known to ask for the test and have left not knowing their HIV status. And oftentimes when I get the opportunity to speak to older women who say that I was tested for everything but HIV, because that there had been some assumptions made based on age and gender or marital status that this woman is not at risk, instead of just universal testing in a place like an emergency department. Also, when we talk about outcomes in terms of HIV care among Black women, we have to acknowledge that there have been reasons in this country for people of color in general, but specifically Black women, not to trust our medical care system. I would encourage any individual who works in our healthcare to read this book, Medical Apartheid by Harriet A. Washington. This book talks about the medical abuse of Black people during slavery, the medical racism that was meant that enslaved people, acknowledging that enslaved people could not consent to experiments on them. And then furthermore, due to cost and the low value placed on the lives of enslaved people, plantation owners often, they didn't make medicine available until the circumstances were dire. Often people were past the point of any help. And so this book carries us through the antebellum period, and looking at a specific story as it relates to women, of sharing the story of Anarcha, who was a woman who had over 30 gynecological exams on her that she couldn't consent to. These exams happened without any anesthesia, and a lot of what was learned from those surgeries from her helped build the career of Dr. J. Marion Sims, which is known to some as the father of gynecology. Then this book goes on. It talks about medical abuse after the Civil War. It looks at things such as the Jim Crow laws and poverty, and how there continued to be substandard care even during this era. And then a few stories that, we talk about the Tuskegee experiment and use that as the foundation for why people of color have challenges trusting the medical care system. But these are also two reasons that highlight the impact of abuse with women. And one of these is from a woman named Henrietta Lacks. Many of you know this story. Henrietta was diagnosed with terminal cervical cancer, and without telling her, a doctor at Johns Hopkins snipped her cells from her tumor. They were kept alive, and scientists found that they could reproduce indefinitely. Again, and so this happened without the consent of her. and her cells were used in many medical advances, including, immunizations for polio. And then Fannie Lou Hamer, who was a civil rights leader. And this also speaks to, we create a profile around this abuse happens to well-educated individuals. But Fannie Lou Hamer was a civil rights leader, leading movements in the state of Mississippi. And even she wasn't exempt from what was called the Mississippi appendectomy, where regardless of what a Black woman went in for, whatever her health ailment was, she was provided with a hysterectomy. And oftentimes this happened without the consent or Black women even knowing that this was happening to them. And the reason that it was happening was that this was to control the Black birth rate in a state like Mississippi, where the majority of the population was Black. And so when you think about these types of events that have occurred in the name of medicine, that it gives reason for why there's a lack of medical mistrust within Black communities and also among Black women. And of course, we couldn't leave this discussion without at least sharing about the Tuskegee syphilis study, which is probably the most known study of medical misuse and abuse to Black people happening in Tuskegee, Alabama. We oftentimes talk about the Black men, but there were women and children who were also diagnosed with syphilis because these men were untreated, and they were lied to and told that they were being treated for syphilis. And it's also important, to acknowledge, and this is always a touchy subject when I bring this up, but that there was a Black nurse, Nurse Eunice Rivers, who was a part of this. And some people say that Miss Rivers was, a product of this era of medicine, and that if she wanted to continue to practice medicine as a nurse, she had to adhere to the, protocol of this story. So some people, see her as a villain. Other people see her as a victim. But either way, this was someone who played a key role in this study that the community trusts. And so I'm bringing up her name for those of us who are fortunate enough to have built trust within the communities that we are serving. It is necessary to constantly ask ourselves, are my motives pure, and am I doing what's in the best interest of the people that I am serving? What we've learned in spite of all of these issues around stigma and medical mistrust and low income and all the other intersectionalities that impact health outcomes for Black women, that Black women are extremely resilient, that you still see such pride within the community that they are serving, feeling empowered to be involved at every stage. And it's important for us as providers to ensure that we are supporting that empowerment, whether it is having women participate in the levels of the program design, all the way through implementation of services that are being created within, for them within their communities. It's also necessary that we create environments where individuals that we are serving feel affirmed, and that they are a part of the decision making in their healthcare practices. spirituality has always been a key component within Black communities, and even serving individuals where the way that an individual may describe their faith or religious belief may not be something that we adhere to or believe in. It's important that we don't denounce that for the women that we are serving. I was very fortunate to participate in this project with the Black AIDS Institute as they did a tour across the country, speaking with Black women to identify, as they were creating this media marketing campaign, what the images should look like. And it was so fascinating to me to hear individuals say, don't forget about the sexy senior citizens. And you'll see, that there are women over 50 that were part of the campaign. And they would say, we're the women with, darker skin tones, with natural hair, women with disabilities, showing young women who may be pregnant, but they are still empowered to take charge of their health care. And so they rolled out these series of images that have been used by health departments and community organizations all across the country to show that Black women are taking control of their sexual health and choosing PrEP as a prevention option for them. And just moving forward, some of the things that we don't want to do, and that is if we identify within our organizations or our public health institutions that we're not being, showing cultural humility to the clients who are coming in, the worst thing is to do nothing. That we have to look at, oftentimes we put the onus on the people that we serve, but we have to look at the environment that we have created for people who are entering into our places of to access health care services. Do those places identify or say that you are welcome or that we are client-centered? So we can't just sit on the sidelines and don't do anything, nor should we become defensive when folks complete the client satisfaction surveys and give us poor marks. We need to look at those things and identify how we can make our services better. It's also important that, we acknowledge our own bias and remember that when we are serving the public, it really isn't about us. And that I'm not so busy in trying to see X number of clients each day that I don't take time to not only see you, but hear you, and acknowledge what may be going on with you and validate that those are real concerns. That helps to build rapport and trust. It also helps to build a relationship with someone who will continue to access services. It's also important for us to be the change that we want to see. That this not only comes from the job description of I will, serve the public without, any biases or whatever. It comes from a personal commitment that says, I'm going to be the change agent. And when I see things like racism or sexism or homophobia or transphobia, that, I'm committing to call that out and to help make the changes that are necessary to create the environment where people of all diversity can access quality care from our place of service. So I'm going to stop there. I know I ran through things quite quickly. I have 1 minute left, and then I'll ask if there are any questions.
Thank you, Alicia. for your great presentation. Thank you so much for all your expertise. And I also want to thank Southern AIDS Coalition and Marcus Harris for helping us and supporting and partner with the National Center for Health and Public Housing. So before we go to the Q&A session, just some housekeeping items. Remember that session 3 will be on March 9th from 1 p.m. to 2:15 p.m. So if you would like to ask a question to the presenter, please either use the chat box or if you are dialing in through your phone, you can use the raise hand icon and the line will be unmuted. And before we get into the Q&A session, and while people are either typing the question or trying to talk to you, Licia, I have a quick question for you. You said in one of your slides about the value identities can lead to microaggressions. Can you please be more specific on the microaggressions that you were discussing?
Sure. So when we talk about microaggressions, I mean, they can come in varying, very different forms. So, for example, like telling inappropriate jokes as it relates to race or gender. Validating one gender or race over another. Using sexist language. I'll tell you one that my 15-year-old came home and we had to discuss. He said that a teacher referred to a Latino student as an illegal. And she wasn't sure what that was, but why it made her feel sad. Those were her words when she heard it. And so we talked about, folks using different microaggressions sometimes as a way of, shaming other race or ethnic or gender groups. Sometimes it happens and it is unintentional. People sometimes may not know that they are speaking from a place of privilege and may comment that can be derogatory or inappropriate to other groups. So those are all just different versions of or examples of microaggression.
Thank you, Licia. And there is one question in the queue. Fide, can you please read the question?
Mary Prim says, how do you encourage those to seek services when their level of medical mistrust is overwhelmingly high?
Yes, that is a great question. And it would be nice if someone, walked into a facility and said, okay, I just believe that this time is going to be different and it's going to be a clean slate and I'm going to give you the opportunity to show me that, that you do care about my needs. Oftentimes it doesn't work that way. And so what has to happen is, different communities, you got to win them over. So they've got to see you within their community. Things like participating in different health fairs or community events. I've also learned, and my mother taught me this as a nurse, that not only does the message matter, but the messenger matters as well. And so if, you provided quality care to certain individuals, word of mouth goes a very long way. And people will say, oh, I don't go to agency X because they looked down on me when I got there, but I go to agency A. From when I walk in the door, they refer to me as ma'am, and they have child care and those different things. And so because I trust this person, they're part of the community that I am from, I'm more likely to give it a try, even if I've had bad experiences with other healthcare organizations. Yeah.
Excellent answer. Thank you, Alicia. Any other questions in the queue today?
Not at the moment, but Sierra Brown said that this was a great presentation.
Thank you so much. I really do appreciate that. You know, the goal is to always make sure that the participants can take something away that can help them in serving, you know, their client population.
Thank you, Alicia. One question, and this question is coming from me. You said something, or you mentioned a stigma and fear of the stigma, and we have health centers participating in this live activity. And basically, my question is how stigma or fear of stigma can affect HIV testing, and what strategies can health centers use to increase testing?
Yeah, so that's a very good question. I think stigma can impact HIV testing in various ways. It's one thing if HIV testing is integrated as a part of like an overall annual exam or things like that versus, oh, if I go over here and I get tested at this organization, what are people going to think about me? And I know those of us in healthcare would think almost 40 years of dealing with HIV that's not a huge issue. But trust me, it still is. You know, that women talk about, oh, well, I'll get tested during National Testing Day, right? And then I can say, oh, I'm just being testing because this is an observance, not because I have identified risk and I need a test. And so what that says is that there's still such shame and judgment that's associated even with a prevention strategy as being tested and knowing your status. So we have to continue to, you know, raise awareness. We have to continue to create these environments where there's less stigma associated with testing. And part of that is including HIV testing within other you know, testing events, so that you're doing blood pressure screening and HIV testing and glucose testing, and it doesn't stand out as much as when we have just HIV testing specific events. One of the things, I'll say this and then I'll stop, that in HIV that we have to get away from is siloing our HIV movement because so much of what we do is integrated into all of these other existing structures, and testing needs to be a part of that.
Thank you, Alicia. That is interesting, and thank you so much for your expertise. Any other questions in the queue today?
Not at the moment.
All right. In the meantime, this is an invitation to the 2020 Health and Public Housing National Training Symposium. We are hosting this event June 18th and the 19th. You can find additional information on your website, www.nchph.org. And for those interested in the slides and the recording, the slides and the link to the recording will be sent to you after this webinar. And you can join us to get HRSA updates and Medicare updates and information on upcoming webinars and other resources that we offer. You can visit our website again, www.nchph.org. You can get additional information on live interactive maps. These are maps where you can find social determinants of health affecting public housing residents, and the location of the health centers that are in or immediately accessible to public housing. You can also contact any of our members, and please do not, don't forget to complete the post survey. Your information and your feedback is very important to us. And before we end the webinar, just let me ask one more time if we have any additional questions in the queue.
No, no more questions.
All right, thank you. Again, I would like to thank Alicia and Marcus Harris and Southern AIDS Coalition for this wonderful, wonderful live presentation. Remember that we have another one, March 9th, and thank you so much for attending this live activity. Have a great afternoon.
Thank you.